Our next guest speaker is Dr. Peter Bagshaw. He's a GP and Associate Director for Mental Health and Dementia with Somerset CCG. He's the Dementia Lead for the Southwest Network. He has a keen interest in metabolic health and has also written a book on the nature of reality. He's also a black belt in Shotokan Karate, which we were hearing about last night, so we'd all better be very nice to him. So thank you, Peter.
Thank you very much. I only put that last bit in case there are difficult questions at the end. So, declaration of interest, none. In fact, I have been invited to other talks in the past that a drug company funded, and I suspect those invitations are going to be withdrawn as a result of today. And I'm here, like all the speakers, doing it because we're passionate about this. I personally, through a combination of low carb, real food and exercise, lost 2.5 stone, joint pains disappeared, I feel sharper mentally, and I'm still practicing at a very advanced age. And have seen that spread out towards patients and seen the benefits. And we're hoping to spread that message to you guys, so you in turn can spread it out. So just a little bit about dementia. You, sir, asked about dementia, and I was delighted that you asked about it from our esteemed consultant cardiologist. So at least it shows there's one person interested in dementia in the room. To answer your question head on, you're right that dementia is increasing, so it's currently about 880,000 in the UK, going up by about 2% a year and reckoned to double within the next 30 years. Mainly that's due to demographics, because of us living longer. There's been a little bit of a drop because of the reduction in smoking, which has actually slowed the expected increase, but because of metabolic dysfunction, we're actually seeing a compensating rise because of that. So, I don't know if you want me to go into the different types of dementia. I'm more focusing on the metabolic effects rather than actual dementia. So it's a neurodegenerative disease. It's not a psychiatric disease. It's just one that happens to have behavioural issues. And there are different types of dementia. So the commonest is Alzheimer's, and that's characterised by, I'm sure you've all heard of it, these proteins, tau and amyloid in the brain. Second is vascular dementia, and that's thought to be due to poor vascular, as one would expect from the name, but it's not quite that simple. And then you've also got DLB, dementia with Lewy bodies, which is associated with Parkinson's. And it's really interesting. The point I want to make is that although there are these different subtypes, actually, I think that most of them have a common root cause. And it just happens to be which bit of the brain it hits as to the way it affects you. So if it's your frontal lobe, you'll get frontotemporal dementia, which is disinhibition and things like that. So I really want to debunk the amyloid and tau myth. Yes, we know that's present in Alzheimer's, but there have been lots of studies now, 30-something, focusing on that, and they've all failed. They're resurrecting a couple that have marginal benefits, but they're really very, very slight. And there have been drugs that are very good at clearing amyloid from the brain, but not actually improving clinical function. So I think the growing feeling, even amongst the proponents of the amyloid hypothesis, is that these are probably simply biomarkers of neurodegeneration rather than being causative. Maybe wrong, but that's the way it's looking at the moment. So some of you may have heard of the Blackfriars study. This came out maybe 5 years ago, and it was the first attempt to try and look at risk stratification. What are the things that make dementia more likely? After that came the BMJ study that showed it very well graphically. You probably can't see this at the back, but we're going to come back to that in a minute. There are a couple of other slides that are quite complex that you deliberately won't be able to see at the back because they've got lots of difficult science on that I can't explain. But they will be available to you when I'm safely back to sunny Minehead and away from being able to ask difficult questions of. But that was really helpful in terms of the causation of dementia. And it looks as though about a third of cases of dementia are preventable. And people argue about whether you should talk about prevention or delay. It doesn't really matter. If you delay by 5 years, you halve the number of cases because we die of other things. So as I was drawing these slides together at the end of last year, this Public Health England thing came out, and I thought I'd go through that first because it really emphasises that dementia is just one of the degenerative conditions that clusters together. It's not a standalone disease, it's a marker of other things going wrong in the body. So what they looked at was, in the same age-matched group, whether people with dementia were more likely to have comorbidities. And the answer was, very clearly they were. So you're much more likely to have hypertension, diabetes, stroke, CHD, depression, COPD, Parkinson's. Parkinson's, I think, was no surprise because we know that if you've got Parkinson's, again, that's neurodegenerative. 100% of people with Parkinson's, if they live long enough, will probably get Lewy body dementia. But the others was a surprise, and I was asked to write an article on COPD, breathing problems, and dementia. And originally I thought, well, the only thing I can say is that if you've got dementia, you won't remember to take your drugs. But actually, there are common things that cause both. So you're much more likely to have COPD and asthma and other breathing problems if you've got dementia. And this is what we're going to get onto later. So there are certain differences between the subtypes of dementia, but I don't really want to dwell on that, because although we do make these differences, Roger Bullock, who's a very famous psychogeriatrician, says it's all brain rot, and he's kind of right. The rarer subtypes have different causes, but actually by the time we're 85 with dementia, 80% of people will have mixed dementia. There's been this new type of dementia, late, which is a completely unpronounceable acronym, but they think that's a different kind of dementia. But I don't think we should get too hung up on these. There was a study from the British Heart Foundation. You probably saw their campaign saying you can reduce the risk of vascular dementia. It's not like that. You reduce the risk of Alzheimer's dementia and all types of dementia with these lifestyle changes. So going back to that slide I showed you in a hopefully easier to read form, so you will see that the risks for dementia are pretty much the risks that Asim was talking about earlier for heart disease. Hypertension, obesity, smoking, physical activity, diabetes, and I'm talking about type 2 diabetes here, just as a shorthand, not type 1, which, as you pointed out, is a completely different disease. So when you see diabetes, I mean type 2 diabetes. There were a couple that were specific to dementia. So depression and social isolation. And there is some interesting evidence about why that makes dementia more likely, to do with cortisol, stress hormones, inflammation, and things like that. Hearing loss, we weren't quite sure whether it was just another marker of neurodegeneration, but there's been some research that came out after I'd actually put these slides together that shows that, in fact, if you fit people with dementia with hearing aids, it does improve their function a little bit. So it seems to be partly causal, presumably because of the social isolation factor. So I was asked to speak at the Primary Care Diabetic Society last year about the links between dementia and diabetes. And I put this together from standard textbooks, trying to work out the links between all these different conditions, because they all link up together, as you can see. And in fact, some people have come as far as to say that dementia is type 3 diabetes. I think that's overstating it, but it gives you a flavour of where people are coming from. So this is what I put together 18 months ago. I think this is now out of date. So already I've changed my thinking on this, not because of anything that's come from medical sources, but thanks to reading research papers that are published on Twitter. So the old method of looking at this is to say hypertension, diabetes, those sort of things are risk factors that then lead on to dementia. So the slide on the left is the standard way of looking at causation. I think that probably is not right. And I think, and Campbell, I'm sure you'll talk about insulin resistance and metabolic syndrome later on, won't you? It's been mentioned already by a couple of speakers, and it looks as though that seems to be the underlying factor. So I think that dementia is just one of the end products of insulin resistance, inflammation, neurodegeneration in the body, along with all the other things. And those of you who tried low carb with your patients will know that they report feeling sharper mentally, but they also report that their joint pains go away and they feel better in other ways. So I'm sure if I'm asked to speak, not by a drug company sponsored talk, in another year's time, this one will be out of date as well. But that to me is my personal best guess as to causation. Does it matter? Yes, it does, and we'll come to why it matters. This is another slide that I've tried to put everything together in. I spent about 3 days working on this, and again, I'm sure I got stuff wrong, and I would be really glad to hear from you. So I'm happy to make these slides available. I know, again, it's rather small print for those of you at the back. I have actually already published it on my Twitter feed, so please look at it, and if there's stuff I've got wrong, please correct me. I'd love to update this. So this is trying to look a big picture, not just dementia, but everything about the things that cause degenerative disease, chronic disease. Unfortunately, I put in red all the things that make it worse, and in green, things that make it better. And you can see there's a lot more red than green, unfortunately. So the green things are resistance training, HIIT, and neuroprotective factor, that's from sleep, basically. And there are certain genetic things that give us protection. But most of the stuff around in the environment which make us worse. And a new one to me, I don't know if any of you have come across it, air fresheners. They listed 4 environmental toxins, and amongst the top 4 were these plug-in air fresheners because of the chemicals they release. And as Asim was saying later, lots of toxins in vegetable oils, seed oils as well. So we're looking basically at degeneration. And this is a slide that I haven't done, somebody else, which is why it's much prettier than my PowerPoint attempt. Looking at senescence. And so senescence is occurring throughout the body as we age, and it's occurring in the brain as well. And I think that dementia can be seen as, in Roger Bullock's words, brain rot, where the senescence of neurodegeneration outweighs our ability to regenerate. And unfortunately, as you know, nerve cells have a limited ability to regenerate. So by the time you've got your dementia, it's going to be difficult to reverse it, unlike type 2 diabetes, where David and others have had fantastic success in actually reversing type 2 diabetes. You can't quite get that in dementia because it's a bit of a one-way street. So we need to look earlier. And there are lots of studies showing that just like with atheroma, type 2 diabetes probably starts, if you can look at the very earliest biomarkers, about 20, maybe even 30 years before it becomes clinically apparent. So by the time you've got your diabetes, your MCI or your dementia, it's probably a bit too late to undo the underlying causes. So we need to start in middle age. This, I think, is the single most important slide. So again, it's a pretty one, so it's come from someone else. And this is really making the case around this metabolic cause of dementia, which is, I don't know, is this new to a lot of you, or am I telling you stuff you already know? I think it's not generally seen as being a metabolic condition. It's generally seen as being this degenerative condition due to these proteins. Not like that. Much more complex, much more widespread. So again, it's showing you how this works. And in the same way that if you get hyperinsulinemia because we're having lots of sugar and carbs, we get chronic high insulin levels, we then get insulin resistance within the body, and then the cells aren't able to operate properly. And that happens in the pancreas and you get type 2 diabetes, it happens in the liver and you get non-alcoholic fatty liver disease, it happens in lots of other organs as well, but it happens in the brain too. And if you get this over a long period of time, you can get this very strange effect where you can have very high glucose levels in the brain, but the cells aren't able to take it up and use it. So they're sort of starving in a sea of glucose, which is really odd. So the simple public health message that I hope you go out here and spread far and wide is what's good for the heart is, oh, we lost it for a moment. No, what's good for the heart is good for the brain. And although it's an oversimplification, it's largely true. And because Alzheimer's, dementia is the most feared diagnosis in the over 50s, because it's now the leading cause of death, because most of us know somebody who's had dementia, we can use this message to turbocharge our public health message about improving our lifestyle. Because people tend not to be so scared about having a heart attack. They say, oh, I'd rather go that way than cancer or something like that. But actually, they are scared of getting dementia. So using this message, for those of you who are practice nurses and seeing people in your chronic disease clinics, trying to get the message across about why it's important to have good lifestyle, feel free to use dementia as the bogey to scare people with. Now, I said earlier about how it's important to know what the root cause is. So we've seen the slides before showing that hypertension increases the risk of dementia. So obviously, what do we do about that? We give somebody a drug to bring their blood pressure down, don't we? Doesn't work. So if you look at the studies, you will see there, so I'll read this out to you because I think this is quite important. Can you read this at the back, by the way? Some nodding, some shaking your head. I'll read this out. So, despite the speculated relationship between hypertension and dementia, and it's not speculated, it's proven, as the top bit shows, clinical trials examining the preventative effects of antihypertensive therapy on dementia have been inconclusive. Now that is really weird. So that means that we know that there's a risk factor, we're treating that risk factor, but we're not actually improving people's risks. And the way you explain that is because hypertension is not a condition that causes problems. It is another of those things like amyloid and tau that's a marker of poor metabolic health. The estimate is argued exactly over the figures, but the estimate is that probably 85% of hypertension is simply a reflection of metabolic syndrome. And certainly that's something I'm starting to see in my surgery, where if I can get people on the right lifestyle, their hypertension improves and they come off the drugs. So, really important thing to know. And again, like the difference between type 1 and type 2 diabetes, probably there's this small core of people who have hypertension because of problems with their renin-angiotensin system or whatever. But the great majority of us, it's simply a reflection of poor metabolic health. So we've looked at obesity. Now this is not just a trivial factor, increases it by 80%. And I'm taking Asim's notes about relative risk and absolute risk seriously here. But type 2 diabetes, I've seen figures that it increases the risk by 6-fold. And certainly in mild cognitive impairment, the single most important intervention you can make to reduce the 10 to 15% annual transfer to Alzheimer's disease is to reverse their diabetes with lifestyle. I've just used mild cognitive impairment. Do you all know what that is? Do you want me to unpack the term? Or are you happy to move on? Who would like me to explain what mild cognitive impairment is? I've got a few hands. Okay, so mild cognitive impairment is where you've got some problems. So to get a diagnosis of dementia, you need 3 things. You need problems with your memory, amnestic problems. You need problems with processing information, and you need it to be enough to affect your activities of daily living. So you need those 3 things to make a diagnosis of dementia, and then you'll try and subtype. Mild cognitive impairment is where you have 2 out of the 3. And if you've got amnestic and cognitive problems, but they're not affecting your activities of daily living, chances are that's pre-dementia. And we know that roughly 10 to 15% a year will go on to dementia. But it can be reported. And Asim would love this. Statin use linked to dementia. So again, you'll remember that the classic way of looking at it is that vascular dementia is caused by poor blood supply. So you give things that improve the blood supply, and you reduce the risk of dementia. Obvious, isn't it? Doesn't work. Never mind about the, whatever it was, 4.2 days extra that you get in cardiovascular disease with statins. In dementia, it probably makes it worse because of this business, again, that Asi was saying about LDL actually being protected. We need cholesterol for our myelin sheaths and our nerves. And those of you of a certain age, and I suspect not many of you are as old as me, will remember the first lipid-lowering drug had to be withdrawn because unexpectedly people had more car accidents and more suicides. And it looked as though it had a direct effect on their mental health. So again, it's really important to know the root causes. Otherwise, you're treating things that aren't going to help. And let me give an example of this. This is a spoof Daily Mail. David has persuaded me to be one of the people who will be appearing in a low-carb Daily Mail series in a couple of weeks' time. And the editor, the health editor, got in touch with me and said, "Oh, can you be involved in this? And can you send through some work?" And I sent this through and thought, perhaps I shouldn't have done that since I'm poking fun at the Daily Mail. So please don't retweet this particular slide. And when we send it around, I might just exclude it from the pack. But anyway, so I've got the BMJ article. That's take on it is a multivariate meta-analysis into the correlation between hair colour and cognitive decline, opportunities for new treatment modalities. And perhaps you get the clue that it's a spoof because it was apparently written by Mr. Bunbury on April the 1st. So the Daily Mail take on this is shock study shows grey hair causes dementia. Well, it doesn't. Yes, if you're grey-haired like me, you're more likely to get dementia, but the grey hair is another sign of the underlying things, mainly age, but other things as well that cause dementia. As a byproduct, by the way, I don't know if anyone else has found this low carb. A lot of you are much too young to know about it, but my hair used to be white. It used to be Philip Schofield white. And since going low carb, it's got slightly greyer, a little bit darker. So actually there kind of is a cause to it, but only if you correct the underlying metabolic problems, not if you just diet with Grecian 2000. And it's really important that you know this stuff, otherwise you're giving people wrong advice, as I embarrassingly have done for the last 30 years of being a GP. So we'll come back to that slide again. You remember this is the one I think is the most important one. So I just wanted to remind you, drum it into you, that poor diet, poor lifestyle, lack of exercise, smoking, eating high carb, high sugar diets, too much of it, stress, inflammation, all of that leads to insulin resistance, metabolic syndrome, that then gives you your diabetes, your obesity, and your dementia. I think this is also useful for those of you who are talking to patients, because there is this thing about fat shaming, isn't it? There's a little bit of a kickback that you say, well, you shouldn't tell me off about being overweight. I want to be proud of my body, whatever shape it is, and that's great. I'm all for that. But if we disentangle metabolic syndrome from obesity, we're not saying your problem is that you're obese. We're saying your problem is that you have poor metabolic health. You've got metabolic syndrome, insulin resistance, that's leading to a number of other things, including obesity. And as we heard earlier, that can be corrected by a change of diet. And personally, I lost 2.5 stone. I don't know if many other people have come to low carb this way. I came to it for the weight loss and stayed for the mental sharpness and the lack of joint pain. And whether it's real food, exercise, low carb, I don't know, because as you were saying earlier, these health behaviours tend to cluster. But whatever it is, I hope it's added life to my years. So inflammation has been mentioned a bit by other speakers. It's a bit controversial, and I suspect a lot of you in the room will actually know more about it than I do. But there is increasing evidence. unfortunately it's not the sort of inflammation that shows up in our standard blood biomarkers. And one of the problems we've got is that we haven't got simple things that measure the important things. So we can measure blood sugar, but measuring blood insulin, for instance, is really difficult. And likewise, we've got markers for inflammation, but not for the sort of subtle inflammation that's going on at the cellular level. Things like CRP and ESR and our traditional markers don't really show up this sort of inflammation. But I think the evidence is pretty convincing when you look at it. And I absolutely agree with Asim that there's been this really unfortunate thing, hasn't there, that because of the hypothesis that saturated fats cause heart disease, we've been encouraged to switch away from that, switch towards seed oils, and as a result, we've got all these toxins, and we've got more omega-6. And on Twitter, I get criticised for everything, but the one thing I think we all agree on is that extra virgin olive oil is absolutely brilliant. So, I've had my 5 minutes given to me, so I'm not going to linger on this slide, mainly because I don't understand a lot of the science, but it's just to show you that there is some science behind it. And again, this is a busy slide, but it'll be available if you want to look at the difference between the omegas, because a lot of patients don't understand it. I'm really convinced that omega-3 is good news, omega-6 bad news. Tobacco smoking we know is bad, and there's been real-world data showing that because men in particular have given up smoking, that's reduced the risk of dementia. So again, tobacco smoking is just one of these things that knocks off. And then that one is good, physical exercise. Most of us concentrate on HIIT, running, swimming. There's lots of evidence about weight training, strength training, and that improves all sorts of things. You don't have to go mad. I just bought 20-pound dumbbells from Argos and do it in the bedroom for 10 minutes, 3 times a week, and then switch on Joe Wicks and try and keep up with his HIIT. Sadly, my wife tells me I don't yet look like Joe Wicks, but we live in hope. And then the dog that didn't bark in the night, unfortunately, although cognitive stimulation therapy helps, brain training, Dr. Kawashima and the others don't seem to. But doing different things and challenging yourself in different ways does. And I'll just briefly touch on other conditions in which metabolic conditions are helpful or harmful. PCOS, osteoarthritis, which we used to think of as just degenerative, but clearly isn't. You don't get degeneration in the ends of your fingers, and yet you get OA nodules, don't you? So there's clearly an inflammatory element to that, and as I say, non-alcoholic fatty liver disease. And increasing studies showing OA responds to reducing that. Gut microbiome, lots of you in the room, we were speaking last night about this. I think it's important. Is it causal? Is it a marker? I'm not sure. But I put it up there just to show I think it's something we need to think about and we need a lot more research about. I'm happy to say that fecal transplants don't seem to be very effective, which is a great relief. Okay, and in the last couple of minutes, I just wanted to touch briefly on something that we can do to help dementia. Most of us think that dementia is you can't do anything to improve. And certainly the current drugs, the Lepisil and the ACHEIs, are pretty useless. In fact, there are some countries in which they've been withdrawn. And although things like solanezumab is being resuscitated, having failed its primary endpoint a few years ago, I think it's only going to fiddle at the edges. But there is an intervention that does make dementia better. Oh, if I can go back. So, right. So, going back to the fish oils EPA, that's one of the things that helps. And ketogenic diet. I'm not personally keto, but I know a lot of people in the room are. And we know about keto, for instance, in childhood epilepsy. There's some evidence around it in bipolar disease. And it seems to play a part in giving an alternative fuel to nerve cells. So it seems particularly helpful in neurodegenerative diseases. So there's good, peer-reviewed, independent research showing that a ketogenic is worth trying in early dementia and probably other neurodegenerative diseases as well. We were discussing MS, for instance, earlier. So it's well worth a try. And whether that's because it reverses metabolic syndrome, I suspect it's a more specific factor on the nerve cells and giving it this alternative fuel rather than the glucose that it can't use. But you imagine we had a drug that could reduce the incidence of dementia by 1/3 and improve function in established dementia. Everybody would want that drug, however expensive it was. NICE would have to give it. And yet we have established treatments for doing it, and it's called lifestyle medicine. And those of you who are practicing seeing patients, I hope you try lifestyle medicine. It's really exciting. You suddenly become enthused. Patients come back to you, and after years of giving them the wrong advice and then coming back saying, I haven't lost weight, they come back and they say, I feel better, I feel sharper, I've lost weight, it's great. And it absolutely transforms your practice. So there's my take-home point. We can not only increase the chances of adding years to our life, but adding life to our years. So questions, bearing in mind that there I am receiving my black belt certificate. Thank you.
Any questions? Oh, one over there. Yes, Ian.
Thanks. Hi, really interesting. I think dementia's got huge potential with low-carb diets. I don't know whether you've heard about the blood-brain paradox. I went to see Georgia Eads speak, and you may all know about the blood-brain paradox, I think. But she was saying that when you have increased insulin in the bloodstream and high glucose obviously in the bloodstream, you have high glucose in the brain. Sorry, do you
No, please carry on.
You have high glucose in the brain, but you have low insulin in the brain. And the tissues that are quite sensitive to insulin are the hippocampus, which is responsible obviously for a lot of memory formation, and also the substantia nigra, and they have the most dense array of insulin receptors in the whole body. So you've got the condition where you've got insulin resistance in the body, but actually insulin deficiency in the brain. So as you were saying, you've got shed loads of insulin in the bloodstream of the brain, but you haven't got any method of getting that into the cells, so you've affected on your own starvation. So if you cut the insulin resistance by doing a very low carb diet, you will normalise everything in the brain and the body. So I didn't realise you'd said that already, otherwise I would have said it.
I'm really glad you said that as an answer, not a question, because you knew way more than me about it. But yeah, no, absolutely. So I tried to cover on that very briefly earlier. And what it means is that if you reduce insulin resistance, you get rid of this paradox. And also the specific thing of a ketogenic diet, the neurons can't use the insulin because of this, but they can use ketones as a substrate, as a food source. And that's why it probably has this specific effect in dementia. So thank you for amplifying that.
Wow.
And not asking a difficult question.
Any more questions? Yes.
Oh dear, it's from an expert.
Thank you so much.
I think you're all experts here, actually.
Thanks for the brilliant presentation. I learned a lot. I just want to clarify, is there any causal link between chronic alcohol use and dementia?
Absolutely, yes. So there's a specific condition usually called Korsakoff syndrome that is induced by alcohol. Interestingly, it's partly the alcohol itself that causes it, so it's toxic. As you know, alcohol is a toxin, which is why it's useful as a hand gel. Well, that's ethyl alcohol, isn't it? But ethyl alcohol is toxic as well. So you've got the direct toxic effect of alcohol. You've also got the effect on cardiovascular of excess alcohol. You've also got low thiamine, B12, as a result of this. And they think that is probably the primary problem with Korsakoff's. And in addition to that, there are falls. So you know about head injuries being another thing that's been in the news, hasn't there, about footballers not being allowed to head balls. And certainly when I worked in South Gloss, we had this really difficult cohort of young men who were ex-boxers, who'd had repeated head trauma, who got their dementia while they were still young and unable to go around and hit other people because that's what they like doing. So it's multifactorial, but yes, absolutely, excess alcohol is one of the risk factors for dementia.
Any more?
I'm not sure if the number of questions means I didn't cover everything properly or that you're interested.
Not at all. Thank you very much. And can I just ask you practical advice to patients that you give, the level of carb reduction? Do you allude specific about that, or are you just saying cut out processed refined foods? How specific are you being?
Yeah, I think that's got to be up to the individual, hasn't it? I'm not sure that there's good evidence that there's a magic number of carbs to cut out. So I do it very simply. I show them the David Unwin infographics, and I say, look, this is how much soon-to-be sugar is in your pasta and your rice. And so just cutting out that carb portion and cutting out things that taste sweet and are refined and that everybody knows is bad for you. To me, that's the simplest way to get the message across. And there are lots of good cookbooks out there. I'm sure you've read Katie Caldesi and various other people who go into this, but I don't think there's a magic number, and it's got to be different for different people. I couldn't go keto because that means I'd have to give up alcohol. I'm not prepared to do that. So you've got to work with your patient, haven't you?
So this is I think final question. So I'm sure you're aware of it, but I thought you didn't mention it in the talk, and it's about Dale Bredeson's Recode program. So Dale Bredesen is, for everyone's benefit, an American doctor, and he's written a book called The End of Alzheimer's. And I think actually saying the end of Alzheimer's is probably a misrepresentation, because he's really talking about either preventing or trying to reverse dementia as a whole. And he goes through about 36 points of things that you can actually cover. And I thought it's really worth a read, so I thought I'd mention it, Dale Bredesen and The End of Alzheimer's.
I'd agree with that, absolutely endorse that, but I agree it's also overstating it to say it's the end of Alzheimer's. Yeah. Lovely. Okay, thank you very much.